Good evening and welcome to this first webinar, Filling the Gaps, Transitions of Care in PE Management, co-hosted by the Anticoagulation Forum and the PERT Consortium. We're really excited to have you here with us this evening. I want to introduce our panel of speakers that are going to be leading this webinar tonight. My name is Geoff Barnes. I am a cardiologist and vascular medicine specialist at the University of Michigan, and I'm joined by four other excellent panelists, and I'd like for them each to introduce themselves to our group. Allison, do you want to go first?
You bet. Good evening, everyone. My name is Allison Burnett. I am an antithrombosis stewardship pharmacist at the University of New Mexico Hospital in Albuquerque, and I'm the president of the Anticoagulation Forum. And it is a real pleasure to partner with PERT on this webinar this evening.
And Brandon.
Hi, good evening. My name is Brandon Hooks. I am a pulmonary and critical care physician at Ascension Borges Health, and I am the medical director of our PE response team and our PE follow-up clinic. I'm so happy to join the stage with you, Geoff, and others talking about this really important topic.
Thank you, Brandon. Vicki, would you like to introduce yourself?
Sure, I'm Vicki McNally. I'm a nurse practitioner, and I coordinate our PERT team at Royal Oak Beaumont in Michigan.
Wonderful. Well, thank you for being here, Vicki. And last but most certainly not least, we have Rachel. Rachel, would you like to introduce yourself?
Sure. I'm Rachel Rosovsky. I'm a hematologist at Massachusetts General Hospital, and I am president-elect for the Pulmonary Embolus Response Team Consortium, and absolutely thrilled to be here with all of you.
Well, thank you all so much for being with us. We're going to go through and talk about a case and bring in each of our expert panelists here to help us think through some of these transitions of care issues. There are some disclosures and notifications of support that we want everyone to know about, especially as they relate to management of anticoagulants and other therapies related to pulmonary embolism and anticoagulation care. This is also accredited for continuing education credits for physicians, pharmacists, and nurses. So to get those credits, you can click on the link here. We're also dropping that in the chat and follow the instructions. We'd like this to be as interactive as possible. So if you have questions as we're going through the presentations tonight, please click on that Q&A button and send us that question, and we will try and build it into some of the conversation that we're having with the faculty this evening. Again, that's clicking on the Q&A button at the bottom. To get us started, we'd like to start with a clinical case. And Vicki, I'd like to invite you to help us think through and present this clinical case that'll frame our discussion for the evening.
Perfect, thank you. And thank you to the PERT Consortium and the Anticoagulation Forum for inviting me to speak tonight. I'm really excited to share some of our strategies from our hospital and how we improve our transition of cares. So to get started, this is a 59-year-old male. He presented to our ER with a syncopal episode that he had while at work. Prior to the syncopal episode, he did complain of sudden shortness of breath. He was diaphoretic, dizzy, and his coworkers saw him pass out. He fell forward and did sustain a laceration to his left forehead. When EMS arrived, he was hypotensive. He did have 2 recurrent syncopal episodes while en route to our ER. So vitals on arrival, he was hypotensive, blood pressure was 86/64. He was tachycardic with a heart rate of 122, respirations were 24. He was afebrile, and his pulse ox was 98% on room air. So initial head CT was negative. His troponins were elevated. They peaked at 0.81, and his CT revealed that he had a saddle PE extending to the bilateral main pulmonary arteries. His right ventricle to left ventricle ratio was 1.9, and it did show leftward bowing of the intraventricular septum. So for this patient, our PERT team was consulted in the ER. He was deemed high risk, and he successfully underwent catheter-directed thrombectomy. So post-thrombectomy, he was brought up to our cardiac ICU. On hospital day number 2, he was transitioned over to apixaban. Unfortunately, after 1 dose, it was discovered that he didn't have medical insurance. So pharmacy was consulted for warfarin dosing, and he was placed back on the IV heparin. While this was all happening, social work, our financial rep, and care management were all consulted to try to help manage the lack of medical insurance and what he was going to do. So education was provided throughout the entire stay by different providers, nursing, pharmacy, our PERT team. On hospital day 4, he was transferred to our regular medical floor. And then on hospital day number 8, when his INR was therapeutic, he was discharged home. In the plan that social work and care management had coordinated, they supplied him with a 20-day supply of warfarin through our indigent med program. So he actually had medication in hand. He was instructed to obtain a repeat INR 2 days after discharge. And then he was also told to follow up with cardiology, hematology, our PE transition clinic, the anticoagulation clinic, which also requires a primary care visit, and gastroenterology for some esophageal thickening. So he was told that it would all be private pay. So can anybody guess what happened? It's, sounds like a pretty hard plan to follow. So these are just a few of the notes from the chart after discharge. I can kind of summarize it. Day 1, after he went home, the transition nurse called. Day 2, it was the anticoagulation clinic nurse. Same thing on day 3. Basically, he spoke with everybody. They went over the discharge plan. He agreed to everything everybody said. They advised him that each provider visit was going to cost anywhere from $77 to $477 each. And he kept saying he was willing to pay out of pocket. And as you can imagine, he never called anybody back. He got off the phone and would say, okay, I'll call back to schedule, and then never did. So the anticoagulation clinic, within our EPIC, there was an anticoagulation encounter opened up. So the clinic nurse saw that, and it was listed under a provider that was supposedly his primary care. So they signed off with plans thinking that that primary care was going to be managing his warfarin. And unfortunately, I found out he never contacted that primary care. He hadn't seen them in years. So on day 12 post-discharge, he did make his one appointment with me, was the PE transition clinic appointment. So when he came in, he confirmed he hadn't seen any additional providers, but had been compliant with his 7.5 milligrams of warfarin daily. So he actually was in the process of enrolling in health insurance at that point through his wife. So it was commercial insurance, but he had no idea what date it would be active. So pretty scary situation. If you can click to the next slide, Geoff. So fortunately for this patient, he didn't have any adverse events, bleeding, or recurrent symptoms. While he was there, we got stat labs to check his INR, and ended up transitioning him over to apixaban after speaking with his providers. Prior to him leaving, I had him actually call and schedule his follow-up appointment with his cardiologist and then also with the primary care. I didn't really know if he would follow through with scheduling those appointments. And then while he was there, we were able to determine what date his insurance kicked in. So we came up with a plan for him. We were able to provide a few samples, and then he did qualify for that free 30-day coupon, and it would bridge him over until the date that his insurance actually kicked in. And because it was commercial insurance through his employer, or through his wife's employer, he did qualify for the $10 per month copay cards as well. So after extensive education, we did the teach back method. I gave him as much information as I could. He went home and I made a follow-up phone call to him the day after and 3 the following week because I just wasn't sure, what was going to happen. It was a scary situation, and I think it identified so many gaps that can happen in the transition, even when you have scheduled processes in place. He had drug in hand, and he had follow-up phone calls and appointments that he was supposed to set up, but unfortunately, he told me he was very overwhelmed and didn't even really know where to start. So he definitely needed more assistance than we had provided.
Well, Vicki, thanks for sharing this story. And I think it's probably a story all of us can relate to, whether we are involved on the PE side of things or on the anticoagulation side of things. I think this is something that we have seen time and time again and really raises a number of those transitions of care issues. I think we could maybe start at the beginning of this case. This was a pretty significant PE, and this gentleman ended up in the ICU. And Brandon, I wonder if you could walk us through some of the issues that you think of as a critical care physician from the ICU and how you transition folks out of the ICU. What are some of the issues you think of there?
Yeah, I'd be happy to speak about this in greater detail. So we know when patients are admitted to the ICU, in fact, that might be actually their first starting point in their hospital admission, whether or not they're in the hospital or actually in transit, coming from another hospital to receive further advanced care. You know, the demographics of these patients are quite critical, either with intermediate or high-risk pulmonary embolism, who have either had a planned intervention or received advanced therapies. We know when these patients arrive, it is not just one service or one team involved in their care, but multiple teams involved in their care. As mentioned in Vicki's case, this patient had a lot of specialists that were involved in their care, which is something that we see often with high critical patients with pulmonary embolism. The ICU care is a continuation and it is fluent. We know that hemodynamic evaluation is ongoing as we see clinical progress. And there is transitions of care that we have during those periods of time with post-procedural or interventional monitoring, but also with the transition from parenteral to oral anticoagulation. What I might add and state that we often have no specific guideline to navigate us from when we start to when we transition, the appropriate timing or interval that we do that. I can say from experience, and what is practiced most commonly is a transition following 24 hours of care with standard therapy after an intervention. These are clinical situations that we run in that are difficult to navigate. When we speak about anticoagulation in these high-risk critical patients, I feel that the ICU should be the starting point where we start talking about conversations. As this might be the starting point of their hospital mission, we should have the starting conversation with patients, their families, as well as other members involved in their care. How does that care look like? And do we have any structure? This is a great pyramid that I pulled from the AC Forum from a prior guideline about transitions of care. And as we know, one of the things that's most crucial is having a concise plan with written and verbal communication. And this conversation is not only with you and the team, it's also with other specialists that are involved in their care.
You know, Brandon, I'm wondering if we could talk for maybe just a minute. As an ICU doc, you're often sort of quarterbacking a lot of different things that are happening, right? Different specialists are coming in, giving advice. You're getting information from maybe the ER where the patient first arrived. How do you keep track of that information in a way that you know you can pass it on to whoever's going to care for this patient on the floor so that it's not overwhelming, it's not an encyclopedia, but that you're still able to pass along the most important information about why the patient arrived, what decisions were made for therapy, and what plans you have for the future? Can you talk a little bit about some of your strategies?
Yes, what I could tell you in my current hospital, one of the things that we've done to eliminate this, transfer of information is actually providing a transfer summary from what had happened within the ICU and what are the follow-up steps. So we always have a brief summary of the events, the interventions, and then next steps in regards to our consultants, as well as next steps that we need to do, meaning, transition the patient from parenteral to oral, or follow-up imaging, echocardiogram, venous sonography, etc. I think that's great to have within the notes, but also direct communications with the receiving teams, our hospital colleagues, so that they are made aware of that.
One of the issues that came up in the case, and I think you also mentioned it, is sort of this transition from parenteral to oral anticoagulants. And my sense is that different hospitals manage this in different ways. So it sort of depends on how long you keep a patient in an ICU, say after they receive TPA or a catheter-based procedure, or even if you're just being conservative, if you're watching them. And I'm wondering, are there standards for how long patients are kept in the ICU, or is it really variable? And how do you think about the role of choosing parenteral versus oral anticoagulant as an ICU physician?
Those are really good questions, and I hope that I could answer them all. What we know is some of it is gestalt with your assessment of the patient following the interventions and how they are clinically doing as a sign of improving, making that transition. Other things that I could just say openly is we don't really have a specific guideline. As you said, some people practice differently in other institutions. We don't have a foundation of when and how and timing to transition those patients. It also depends on the interventions that we have. We know when patients have systemic thrombolysis, we are providing that to them, but we are also, careful with the administration of heparin. And sometimes even some procedures that we have, some patients may not even require ICU stay, depending if it's a, mechanical lumpectomy. But a lot of it is also dependent on ICU stay. So that for me as an intensivist, I am constantly evaluating that. Some of it was clinical experience, just thought of the patient's improvement in hemodynamic stability. And when we are transferring those patients, it's a clear communication that we are, de-escalating our therapy and working on transitioning those periods. The other thing too that I often like to do is get social work, case management involved in these patients early, so that we could at least start assessing insurance very upfront with their hospital admission, instead of, as Vicki alluded in her case, midway throughout their hospitalization.
Yeah, that's a great point. And as I think back to the time I spent in the ICU when I was in training, and certainly now as I work on the floor, we think a lot about insurance coverage as a floor physician and sort of what am I doing to set somebody up to go home. But in the ICU, you're often just thinking about how do I get them to the next day, and sort of their outpatient insurance coverage may not always be at the forefront of the mind, but clearly it's so important for this particular care transition and management strategies. Are there systems in place at your hospital that sort of help you think about that early on, or are those really more designed to happen prior to discharge?
At my hospital, I will say no place is perfect. A lot of it is the input on, the physician. We do have a case manager that follows within the ICU, the progress, but early awareness that this is something that's going to be needing for the patient, so that they get on it sooner than later, I think helps, so that we could better identify whether or not they have insurance coverage for direct anticoagulation. And those patients too, Geoff, we might actually start them on warfarin therapy in the ICU. So that's another thing if we have insurance hurdles. But most, as you had mentioned, it is something that is seen on the floor prior to discharge.
Well, I'd like to move this case along a little bit more, and I actually want to bring Vicki back, if she doesn't mind, to help us talk a little bit about the patient on the floor. You're getting ready to send them home. What does that transition of care look like, and what things should we be addressing there?
Thanks, Geoff. Yeah, so floor to home is a really important time for the patient in terms of lining up and solidifying all their plans. So I like to look at it as helping the patients to get all their ducks in a row to make sure that they're adequately prepared for that transition home. So 3 important areas that I'll focus on are the plans for anticoagulation, again, making sure they can afford their medication, understanding how and why they're taking it, risk of bleeding, and I'll go through a couple examples of how we've worked to improve the anticoagulation planning. And then the second point is the plan of care and follow-up. It's important to establish and define, as Brandon mentioned, there's usually so many different providers involved in these cases, and making sure everybody's on the same page and that the plan of care is documented is huge. And then also including the patient in that as well. And the third part, patient education is important everywhere, so you can never say it enough. So in terms of anticoagulation cost, just to kind of piggyback off what you guys were discussing about getting care management involved early. So something that we've built within our IT Epic environment, we have an inpatient DVT and PE admission order set. So right when the patient's diagnosed with a PE, these orders go in. And in the red box, you can see the consult to care management. It's always pre-selected. So right out of the gate, the patient is started on whatever anticoagulant, and the care manager is notified that this patient's going to be going home on anticoagulation. Please look into insurance coverage, and then also what their copay is and if that's affordable to the patient. So that kind of gets the ball rolling early for us, and I think it's definitely helped. The second part is the coupons. Having these available to everybody. I've noticed that if people don't physically have a coupon, they're looking for them. But to make it easier, we worked with IT and had them enter the hyperlinks for both the Rivaroxaban and the Apixaban coupons. So right in Epic, you can click that link and the individualized coupon card comes up and you can print it off for the patient right then. So it really eliminates the need to have those physical coupons and have to find them for the patients. And I think a lot of people, in our hospital at least, are not aware that that's an option. So I like to try to promote that as much as I can. And then the Meds to Beds program, I know a lot of facilities have this, and it's really important for VTE. I think making sure that that patient physically has their prescription before they go home. I mean, it eliminates all issues with applying coupons or running the patient's insurance because they physically already have it before they go home. So I think these components have really helped us in terms of getting anticoagulation coverage and the medication physically in hand. Another thing that I had kind of picked up on, this was maybe about a year ago, some of our patients that were following up in the clinic, we had them set up to go home. We knew their copay, they had coupons, but if they filled their prescription at a retail pharmacy or an outside pharmacy, sometimes the coupons weren't applied correctly or their insurance didn't go through. So they're coming to me with just a week's supply that they had to private pay for. And when we started looking into this, we were able to find our order sets, and we realized that in the ambulatory and like the discharge order sets for providers, our medications for Apixaban and Rivaroxaban never included the phrase starter pack. So people were typing that in and looking for it and they couldn't locate it. And then when they did find an option where they could enter the information, it was always having to manually be typed in. So attendings that might not be familiar with the dosing frequency or quantity, I mean, if they're not ordering it every day, it leaves room for error. So we worked with IT and pharmacy and changed the name up. So now they include VTE starter pack as an option. And then we also pre-populated into the provider's preference list. So now everybody can find the orders and they're easy to click. You review dose, frequency, quantity, make sure it's going to the right place. And we've seen good outcomes with that working better for the patients. And then again, in terms of plan of care documentation, making sure everybody's on the same page and that everything's clearly communicated is huge. So we actually, under specialty, have pulmonary embolism response team, or PERT, built in. So you'll see pulmonary, cardiology, internal med, and then you can easily identify the pulmonary embolism team and what the patient, what their risk stratification was, what they had done, if they had any procedural or TPA-based therapies, and then also what the plan is. So recently when we opened our PE transition clinic, we were able to build a dot phrase so that all the information that the providers needed would be in this plan of care. And I noticed that that wasn't really helping get our patients to me. So now when I follow up, I actually go into the discharge section in our Epic and manually enter in the follow-up discharge instructions, the follow-up with the PE transition clinic, the phone number, and then the time frame that I want to see them in. And I've noticed that that really, really helps in getting patients to actually call and come see me within a week of discharge. And then again, it can't be mentioned enough, but patient education and making sure that they understand is just so important for all these patients at every point in the care. Assessing their understanding, making sure you're asking questions, doing teach back methods, and also providing printed material. We have a nice brochure that I'll go through, but I love to circle things, write notes, anything you can do to help reinforce the teaching and concepts that you're providing, I think is really helpful. And then again, using plain non-medical language is something that I hear from our patients constantly. It's really important to make sure they understand what you're talking about. And this is our education booklet that we've put together for our hospital. So I bring this to patients when they're inpatient, and then again in the transition clinic, I bring it to them and review it. It's really a nice overview of all the important and crucial teaching points. So I go through it with them. If there's a risk factor that they have, I can circle it or write it in, and we go over the different symptoms for DVT PE, when to call 911, when to get medical attention, when to contact us, all the different options that might be needed for the patient. And the last 2 pages of the booklet are specifically focused on transitioning. So from the hospital to wherever they go next. There's a nice checklist that kind of reemphasizes all the points we went through. And then the last page, we have our pre-populated information for the PE transition clinic. I usually staple my card with my information. I'm really the contact, and I tell them anytime, it doesn't have to be right after hospitalization. It can be 6 months down the road. If you have an issue with your VT management, please call me. This is what I do, and this is what I'm here for. So we make sure they have that information. We have our anticoagulation clinic information. I'll fill in the PE doctor because we do have various specialists that manage PE at our hospital, and then any other applicable notes I like to write down just to make sure they have it when they go home.
Well, Vicki, thanks so much for sharing all that. It sounds like you've really put a lot of thought into how you're handling this transition of care and providing the necessary resources for patients in this hospital to home period. Brandon, have there been some questions coming in from the audience around this? Anything that you want to pose to Vicki?
Yeah, Vicki, I think you bring up a very good point about med to bed, having the medication available in hand before discharge. What are your thoughts of also having a appointment scheduled for patients prior to getting in the hospital and not relying on that follow-up or number outreach? What are your thoughts on that?
Yeah, so that's something that it took a little time to realize, but when people don't call and schedule the appointments, you start trying to figure out why. And that's definitely something that was brought to our attention, and that I work really hard with patients, especially the patients who might have trouble with that. And another thing, I always ask where the patient lives. Do you have somebody to drive you? Are you able to drive yourself? Do you work? Do you live close by? I mean, if you don't ask, you don't really know. I've had patients that don't have a car, or maybe they live across the state and they were just here visiting family and nobody's really brought it up. So I think really asking a lot of questions and then trying to facilitate whatever the patient needs to get that follow-up in place is really helpful.
A question from the audience was regarding the PERT teams. So how does having a PERT team within your institution help navigate these transitions and interventions? And if they are performed, who is the one leading those conversations?
So at our hospital, our PERT team, it's multidisciplinary. So we have our rapid response team of APPs, so nurse practitioners and PAs. They're the first line. So the consult goes out, they go to see the patient, they risk stratify. And then when a patient meets criteria, so intermediate, high risk, or, just clinically they look like we should probably discuss the case, they page it out and escalate it to our physician. So we have cardiology, who's typically in the role that we call our PERT attending. We have interventional radiology. We have our ECMO specialists if it's a crash call. And then we also have cardiothoracic surgery. We have a lot of different providers on the phone, but they all call in. We make the decision and facilitate whatever needs to happen after that. We have streamlined the patients all going to our cardiac ICU to try to standardize care and everything that comes after, the immediate action. And then as the PERT coordinator, I follow all of our patients. So I get notification of every patient consult and follow up. So I'm really kind of the glue in between the initial response, and then I follow all the way until the PE transition clinic. And then I'm there again if they have any questions down the road.
So it sounds like you really bounce back and forth between seeing patients in the hospital, introducing yourself, making sure they have that good transition of care, and then seeing them again in that follow-up clinic. So you're that familiar face and you can help to bridge that transition. Is that right?
Yeah, that's very correct. And I think too, as a nurse practitioner, I think it's been mentioned before, people don't want to burden the doctors that are seeing them, or, the ICU team it's busy. So they don't want to ask a lot of questions, but the second, I sit down and start asking them questions, people have so many things to ask, and you can identify so many different things that they might need help with or coordination to make sure that they're really safe and getting the best care possible.
Well, Vicki, thanks so much for sharing your expertise and your experience. And there have been a ton of questions around this, so I'm sure we'll try and answer a few of them if we have a little later. But I'd like to move us on a bit in this case. Not every patient is able to go from hospital to home. Many patients end up going from hospital to some sort of a facility. And I'd like to invite Allison to join us and talk a little bit from her perspective, especially as a pharmacist. What do we need to think about as we're transitioning a patient from one facility, a hospital, to another one, maybe a skilled nursing facility or a rehab facility? Allison, can you share us your thoughts?
Yeah, sure, Geoff. Thanks so much. First, just really great discussion so far and so many great ideas around all of these issues. But I wanted to spend a couple of minutes talking about these different types of care transitions for our patients with acute PE who can't go directly home and have to go to some type of post-acute facility like rehab or a skilled nursing facility. And I think, there's some challenges that we see commonly in clinical practice. And unlike patients who can discharge from the hospital to home that have most likely a unified plan on what's supposed to happen that can be shared with multiple providers, it's not unusual for patients transitioning to facilities to end up having multiple discharge packets sent to a post-acute facility. And this is simply because our care management partners are working very hard to get these patients placed in a facility, which takes some time. And in the days leading up to discharge, we all know that sometimes plans change. And so if multiple packets get sent for these patients to a facility where the plan has changed, it can become very challenging for the facility to know exactly what the source of truth is and how they're supposed to manage these patients. Another challenge is that these facilities have fewer resources and infrastructure and cultural expectations around transitions of care. And the clinicians working in these facilities may not have focused training or knowledge around anticoagulants or share the same degree of appreciation of these therapies as vital for our patients. And so I think all of these things collectively, if we have bad information going out of our hospital into the facility, that can lead to problems. Or if we don't have things in place as the patient needs to leave the facility, that can set our patients up for adverse events as well. So this definitely adds, increases the number of critical junctures that these patients experience. And so I think this is definitely something we need to take a closer look at. Next slide. So we've actually taken a look at this within our own facility at University of New Mexico Hospital. And what you're seeing here is data that our care transitions intern team have collected over about a 2-year period. And you can see for adult patients that were discharged to a post-acute care facility on therapeutic anticoagulation, overall about 8% of them had some type of anticoagulant discrepancy when we followed up with them. The leading cause was failure to continue therapeutic anticoagulation in the post-acute facility, which could be absolutely devastating for our acute PE and DVT patients, because these patients, as you know, have a very high risk of recurrence or progression of around 40% in the first few weeks after diagnosis. So a lot of work to do in this area. Next slide. So at our hospital, we're on a Cerner platform, and I wanted to provide some ideas for folks who may be on a similar platform. And these are not, they don't come standard. We had to build these, but we felt that they were very important. So we focused resources towards this. And just to reemphasize, some things that Vicki and Brandon pointed out, it's really important to identify these patients as early in the admission as possible and start that care transitions process. And so what we've done is created some dedicated care plans for these patients. The one I'm showing you here is for catheter-directed thrombolysis. And so when these care plans are used, it triggers an alert down at the bottom of the screen to a dedicated antithrombosis stewardship pool that we have, so we can quickly identify these patients upstream. And Geoff, as you mentioned, these patients are getting started on oral anticoagulants earlier, and getting, sometimes they're even getting discharged from the ICU. And so we want to know about these patients, and we take our stewardship pharmacists and we deploy them to the ICU to work closely with the ICU pharmacists when these patients are found, so we can help them, because they may not have as much navigational experience with care transitions like our progressive care pharmacist on the wards. And similar to what Vicki highlighted on her EPIC platform with the dot phrase, we use a dedicated EHR-based power form to capture requisite data, anticoagulation elements. Getting back to your point, Geoff, of how do you keep track of all this information across the admission and then hand it off to the next care setting? So things like, what anticoagulant is the patient on? Has there been any, assessment of whether this is provoked or unprovoked that might inform duration of therapy? Did the patient receive an IVC filter, and do they need follow-up for that? So several items around that we groom throughout the admission. And then again, can't emphasize it enough, getting all of those ducks in a row that Vicki mentioned. And I think this is really important for patients going to a facility, because recognizing that they're not going to have as much, they're not going to have as many resources as we have in a larger hospital, and perhaps an academic teaching center that are performing these advanced interventions. We need to try to make sure as many of these are in place before they leave our hospital and go to the post-acute facility as possible. So again, determining copay and financial access to these medications. We often have to initiate prior authorizations for DOACs on these patients, and sometimes those are still pending at discharge. So we really have to triangulate that between our team, our discharge pharmacy, and the facility to make sure that that's seen through, and if any changes in therapy are needed down the road, that those are addressed. And again, creating a tether with the patient. So teaching them how to use their patient portal, giving them a safety net contact number, as Vicki mentioned, really important, because while they're going to this facility, they're not going to be there forever. And if they don't have an optimized care transition out of the facility, they could run into barriers or deficits in care, and they need somebody that they can reach out to for help. Next slide. So we've also built alerts in our system to help us identify acute VTE patients that are nearing discharge or that have very recently been discharged, so we can prioritize them, go through our anticoagulation power form note, make sure all of these transition of care elements are addressed. And then once that, that clinical power form note is finalized and we have a clearly documented anticoagulation plan of care that aligns with the provider's discharge summary, we then, our interns then take that information and transmit it directly to the facility as the source of truth, just to reinforce and corroborate information that they may have received. Next slide, please. Another way that we really work to fill the gaps in PE care transitions is we use our team, our stewardship team, as a bridge in between our facility and the post-acute care facility. And the primary way we do this is we use interns, pharmacy interns, as pharmacist extenders. And so using that same anticoagulation power form for documentation, our interns will place a follow-up phone call and a warm handoff to the post-acute care facility about 48 to 72 hours after the patient is discharged. And they have a semi-structured script that they use, you can see here. And really they're having a conversation with the bedside nurse and possibly, you know, the provider to ensure that there's clarity of the plan, that there is persistence of the recommended anticoagulation regimen, and then identifying and any discrepancies that exist. And when those discrepancies are identified, our interns will recruit one of our stewardship pharmacists to have a phone call with the provider at the facility to get those rectified. So you can see here's a patient where the intern documented the patient was supposed to be on a Pixaban induction for an acute PE and was supposed to have their concomitant home aspirin discontinued. Unfortunately, at the facility, they got put on the wrong apixaban dose, severely underdosed for an acute PE, and their aspirin was continued. So all of those things collectively could lead to adverse events. So we know that there's value in this, and our administration has been very supportive in providing us with resources to conduct this service. We also are very cognizant about making sure the post-acute care facility, if there's any outstanding issues like pending prior authorizations, or perhaps we haven't been able to set the patient up with a primary care physician for after discharge from the post-acute care facility, we recruit their help in making sure that continuity of care is in place. So those are just some things that we've done at our small health system out here in Albuquerque. I'm sure there's much more elaborate systems out there, and I would love to learn more from the attendees and my fellow faculty. But I think if we really want to make a improvement in these things on a kind of global scale, I think ways we can do that is to have more anticoagulation stewardship programs to own this and work in tandem with the post-acute care facilities and our PERT teams. We definitely need enhanced anticoagulation documentation to capture more of those requisite data elements. I don't think I need to convince anybody here that we need better interoperability of our EHRs that includes bidirectional communication. So, I can get a hold of, Vicki and her facility and ask, questions and get quick information very, very quickly. And I think ultimately we really need to strive for high quality care across all care settings, including hospitals and post-acutes, and even out in the community and among our specialists, because if we're not all providing high caliber care, the patient's plan can fall apart at any one of these junctures.
Allison, thanks. That was really an incredible overview. And it's great to see this, not just in the EPIC system that Vicki showed us, but in the Cerner system as well, how you've sort of thought through and operationalized this. Brandon, I know we've had some questions coming in from the audience. What questions do we have for Allison?
I had a question for Allison too, and this was kind of brought up in several points of the chat. We cannot stress enough the value of patient education. How do you navigate the patient navigation? How do you navigate the patient education regarding medication delivery, as well as patients understanding the role of the medications and possible interactions? Yeah, how do you tackle that?
Yeah, great question. So we, and I think Vicki highlighted it nicely in one of the opening slides about multiple points of patient education. We try to hit this as many times throughout the admission as possible, partnering with nurses, having pharmacists do education, et cetera. Sometimes, depending on what's going on with the patient and why they need to go to a post-acute facility, they may not be able to effectively receive education, right? And so I think that's another thing that we have to communicate very clearly to the inheriting facility is, has this patient been educated, yes or no? And if they haven't been, thoroughly educated and demonstrated full, understanding through teach back, et cetera, we will ask for their help in more touch points for education and ensuring that they're using the teach back method and understanding at the point of care. So it's one of those things that we do through those warm handoffs. If it's one of those outstanding issues that haven't been addressed, definitely need to make sure that that box gets checked. Now, whether the facility has the same level of, educational materials and will receive the same caliber of education, I think that's kind of beyond our control, but I think that's a good argument for standardizing care and tools regardless of care setting.
So one of the things I was mentioned in the chat was we often see electronic medical records as, perhaps being a barrier. I think what you've identified a good way and solution to use this as a tool in the transition process. Did you have any other recommendations or advice for others that may have similar transition periods where they don't have this resource? How would you provide them with some advice on how to navigate that?
If they didn't have EHR tools and a team?
Yes.
Yeah, it's a challenging question and a very challenging situation. I mean, I guess I would just say, use what you have where you are and do the best you can. If you have to, I would assume most people are at least on an electronic health record. Start conversations with your informatics team if you have that, to just try to start putting together some rudimentary elements. If you can't do that, see what you can come up with in the form of like a standardized document where you're capturing these requisite data elements and physically fax it to a HIPAA compliant fax to the facility to make sure that they have the information they need when they inherit that patient.
Allison, we're getting a number of questions about a sort of a specific, but I think a really common transition to care issue. And I'm wondering, as a pharmacist, if you could weigh in on this. Many of these patients may be in the hospital for 3, 4, 5 days before they're ready for discharge. And they've been, say, on a parenteral anticoagulant for several of those days. We've highlighted the real strength of the starter pack, whether it's the apixaban or rivaroxaban starter pack, to help patients not get confused with the dose change. Do you have them restart the starter pack and get that full 7 days for the apixaban or 21 of rivaroxaban? Or do you sort of discount those first several days that they were in the hospital? How do you think about advising a patient who's maybe going home or going to a place where they're going to use a starter pack? How do they accommodate the inpatient piece that they've already received?
Right. It's a great question. And I think it differs, pretty significantly for a patient going home as opposed to a patient going to a facility, because most often when we're sending patients to facilities, the facility will be providing the medication in most instances. I also think what we weigh into that decision, and it's a common question, I agree with that, is what is the patient's kind of clinical picture and bleeding risk, right? Like, I mean, how aggressive can I get with this? So let's say they're in the hospital and they've had unfractionated heparin for whatever reason, 5 days, and they're going to discharge home. This isn't based on any evidence, but what we might do, just to keep it simple, is to perhaps forego a couple of days of induction if the patient's doing well, et cetera, and send them out on the maintenance dose just to make sure that the patient, it is as straightforward for the patient as possible. Now, if they were only a couple of days into their therapy, maybe they've had, 36, 48 hours of low molecular weight heparin, unfractionated heparin. And we are switching these patients very quickly to DOACs. I think in that situation, I would, if the patient was low bleeding risk, doing well, I would feel very comfortable in just going ahead and giving them the full starter pack and sending them home with that to, again, keep it as simple and straightforward as possible.
Awesome. Well, thanks for that. I'd like to move this case along to our final chapter, and I want to bring in Rachel. We talk a lot about the follow-up piece, and follow-up can involve lots of different people, primary care docs and specialists. Can you help us think through a little bit about who should be responsible for each of those different elements?
Yes, of course. And again, great to be here. Are you able to pull up my slides? Oh, perfect. So I'm going to talk a little bit about PCP and specialist follow-up issues, the who, what, where, when, and how. So we actually looked at this, Geoff, you're part of this, looking at the barriers of VTE transitions of care, and you can go to the next slide. And something I think we've heard throughout tonight is that the key is communication. And it's communication between provider-provider or provider and patient. And really it's lack of a point person. And Geoff, you can go to the next few slides because there were some animations here. And you go to the next slide. So you've heard from Vicki's case that there were a lot of people that might see a patient in the hospital, lots of different specialists. And I think it's critical that you identify who is taking responsibility for this patient. And as Vicki shared, this patient was gonna, oh, you can go back, sorry. That patient was gonna have cardiology follow-up, hematology follow-up, anticoagulation management service follow-up, P transition, the GI, the PCP, there were so many people, but who was actually gonna take responsibility for this patient? And I think every institution has to have kind of a consistent, reliable, clearly defined follow-up system in place and communicated not just to the patient, but also to the follow-up provider. And the patient shouldn't be leaving the hospital without knowing who that person is. Someone needs to own the patient, be that point person, and it needs to be clear to the patient. And again, there's so much confusion in the hospital. Patients see different specialists, and there needs to be one person in charge. And it may be different depending on who sees the patient. For example, in our clinic, in our hospital, PERT patients will follow up in our PERT multidisciplinary follow-up clinic, versus we have an ED program where instead of admitting patients to the emergency room, they get followed up in our hematology vascular specific clinic for just that. So it's also going to depend on where that patient is. You can go to the next slide. So I think we've heard this already, but it's really important when patients are going to see that initial provider, whether it's going to be their primary care doctor or a specialist, and we'll get into that in a second, that all of those people have a complete and timely discharge of their hospital course. And this is especially important if there's different systems involved. So if a patient was admitted to one system and following up with their primary care doctor in a different system. And it's important to follow up in pending tests and to really know what that anticoagulation plan was in the hospital. It's going to be important to know how to drive that forward. Go to the next slide. So when the patient shows up to their follow-up clinic, and initially who that person is, again, is going to be dictated by who is going to be the person responsible. I think the first thing is assessing that patient's understanding and level of understanding, and really explaining the coordination of care. And you've heard a lot about kind of the anticoagulation plan, and this is a key area where I think transitions of care and issues can arise when people don't understand their medication and don't understand the importance of how to take it, when to take it. You heard a little bit about the dose switching when that happens. I think affordability is so key here. And you heard already meds to beds, and patients should have actually their medication in hand before they leave. And if not, I think it's really important during that first visit for the follow-up physician who's in charge of that patient to assess, are they able to afford it? Have they, how much are they paying for it? And can they afford it moving forward? Obviously talk about the bleeding issues. And then the duration of anticoagulation is really going to depend on what caused the underlying blood clot. And again, who's making that decision? Is it the primary care doctor? Is it the hematologist? Is it the cardiologist? And again, it's going to depend on where that patient is being followed. You can go to the next slide. I think it's also important, and this was mentioned earlier, in identifying what the etiology of the PE is when patients follow up. Oftentimes we don't discover it, but it's important that these patients are up to date with their age-appropriate cancer screening, so colonoscopy, PSA, mammogram, things like that. And again, who is taking responsibility of that? If patients were in the hospital and they had an abnormal echocardiogram, it's important that that is followed up. And that's often can be done with a pulmonologist, or sometimes if, for example, if they follow up in our clinic and I get an abnormal echo, I'll then send the patient to our pulmonologist. One of the key areas of concern is when patients have an IVC filter in the hospital, and oftentimes these are left in. So having a follow-up clinic is a perfect place to make sure that you can identify the patients that have that, and then who is going to take that out, who put it in, when should it come out, and how is that going to be arranged. It's important that patients know what symptoms to worry about. A lot of times these patients are so overwhelmed. In fact, Vicki said the patient was so overwhelmed, he didn't even know where to start. And then who and how to call with any questions. Go to the next slide. Oh, there was one part of this was taken out. Another, you can go back to the slide before this. I had one part taken out. So another area, which I think does need to be mentioned, are the long-term consequences that can happen with patients. And so I'm not going to delve into this, but a lot of patients after PE can have long-term consequences like CTEPH or post-PE syndrome. And then something that's quite underappreciated are the psychological aspects, anxiety, depression. And again, in follow-up, it's important that we ask our patients that, and if you're not comfortable treating depression or anxiety, that you have a mechanism by which you can refer that patient. Go to the next slide. So follow-up and when that should happen. So this is going to, again, depend on the system that you have. And there are a lot of systems that will have a nurse or provider call a patient within 24 or 48 hours after discharge to make sure that the patient has their drug, they know how to take it, they haven't any bleeding complications and any questions they might have. I think that critical time from when the patient gets discharged until that first follow-up appointment is where a lot of these issues can happen. And so when they eventually do follow-up can be, within a few days. If somebody's on warfarin, I think obviously they need to follow up fairly quickly to check that INR level. We heard about the DOACs when people switch, if they don't have a starter pack. I think that's another time where you can follow up with the patient and make sure they know when to switch. So really, I think it's probably within the first month, and generally like to see people within the first 2 weeks. Go to the next. And again, it can be a phone call or a clinic. And going back to, primary care doctor or one of the specialists, I think there's a lot of primary care doctors that feel very comfortable taking this on and managing anticoagulation and knowing, when to start it, when to stop it, when to switch it, when to dose reduce, and sometimes not. And so again, figuring out where that patient should go and who is taking responsible for different aspects of the patient's care. And then lastly, the how. You can go to the next slide. So this is an amazing paper by Dr. Hernandez Nino. She actually gave a webinar on There's No Place Like Home, the outpatient management. And she just published this looking at the impact of verbal and nonverbal provider communication on patients. You can go to the next slide. And she has some quotes, and I'll just share two of them. One was from a patient who said, and I didn't know what the heck they were talking about. They said deep vein thrombosis and pulmonary embolism. I knew what a blood clot was. Did I know what a pulmonary embolism was? No. And then the next slide. So that's what the doctor told me. Take it every morning and don't miss it. I said, what happens if I miss it? He said, don't miss it. That was all he said. So I think in that follow-up time, it's very important to actually listen to patients and answer their questions. And this is a question I get a lot from patients. What do I do if I miss it? Do I take it right away? Do I double the next dose? And so I think, again, during the follow-up, making sure patients know where to ask questions, who to ask questions, and then really to listen and answer them. Next slide. So a very brief overview of kind of the who, what, when, where, and how. But I think the key is knowing and having somebody take responsibility for each of these patients during the follow-up. And then whoever is responsible, they have had the communication from the original hospitalization or emergency room or wherever the patient was coming from. And if that provider doesn't know what the next steps are or how to deal with an abnormal test, that they have a mechanism by which they can do that. Thank you very much.
Rachel, thank you. That was a wonderful review. And I know we're coming up here in the end of the hour, but Brandon, perhaps we have time for just one question from the audience to ask Rachel.
Yeah, Rachel, this was a question that came from one of the registrants regarding follow-up in particular. And we know there's a lot of transition points, and we've mentioned this ongoing in the chat with starter packs, with dose reduction in medications, and they're different between both medications. And their question was, how do we navigate that and how do we address that? But also, when patients follow up with us, does the severity of the event also make the time frame which we see them back in the clinic different?
Yeah, so the first one, I think this is critical. If the patient does not have a starter pack, it's really important that they get a phone call at the time that transition happens. I can't tell you how many patients I've seen in follow-up who, you know, are still on the wrong dose. So I think if you can't do the starter pack, there has to be communication. And I think in terms of the follow-up, this is an important one. I think if somebody has been really sick, I don't think you can wait a month. So it's also going to depend on the severity of how sick they were. So I think it's more timely follow-up is key. I love the idea of having, you know, a phone call within the first day or two for patients. A lot of hospitals do that. And if you have the resources, that's an incredible way to just check in on somebody and make sure that they're doing okay. And I would also just want to end one last thing, which I didn't mention, and that is, I think we have to also get the patients to be empowered. You know, a lot of times patients, that first case that we heard where the patient was going to see 27 different people, you know, a lot of times if patients are going to different places, if you order a test on a patient, make sure you give them the result, make sure that they have it in hands with them. When they're going to other providers, they have all the information, because oftentimes this miscommunication, what test was done, what did it show, who are you, that can be avoided if we actually can empower the patient.
So in summary, I want to, as we're coming up to the hour, I just want to express my appreciation for those that were presenting, as well as the AC Forum and the PERC Consortium, and those who attended tonight. This is a CME certification. To collect your certification, please fill out the information with the information posted above. We know this was actually a great event between both the PERC Consortium as well as the AC Forum, which involved multiple people, disciplines throughout a PERC team. Not only physicians, nurses, pharmacists, and advanced practice providers. So we're so happy that you're able to join us. We know actually the education doesn't stop here. We would love for you to be available and participate with us with upcoming events. We have the 8th Annual Pulmonary Embolism Symposium, as well as the PERT Boot Camp for trainees. And this is a hands-on event that will be going in parallel with our yearly annual meeting, as well as with the anticoagulation. For continued education, there is a boot camp listed. Register online. It will be taking place in May. And also join in the future next year with continuation of a great educational event in San Francisco. And we would love to see you there at both events. Thank you again for your participation, and for everybody who helped with the organization and being here today for this great topic.